Hello and welcome to Billing and Reimbursement. We're going to talk about appeals because just because a claim is rejected or denied does not mean that's the end of the conversation. Okay, so first, let's talk about your responsibilities as a medical biller. You are responsible to follow up every claim you send. So it is very, very important that you keep a log. Now, most computer patient management systems, when you create a claim and you send it electronically, because that's the way we do things these days, the computer will create a log. But in an average healthcare facility, even a one physician office, at the end of a week, that list can be incredibly daunting. So you need to find your own workflow, the way you're going to work with this list, and make sure that you know what you send out and then what comes back or doesn't. So we're going to look at what can happen, claims that have been paid by the insurers, whoopee. Okay, that one's easy, and we're obviously that's not going to be an appeal, but you will get notification of how much was paid on the claim. And in most facilities, that will be your job to enter that amount on the patient's record so the patient gets credit for that amount paid. And then, of course, you'll already have whatever the patient had to pay out of pocket and make sure that all jives. Okay. Then, and very important for the next two, which are those claims that you have received a rejection or a denial notice, and for those that you've received no notice at all. No money, no rejection, no denial, because you have work to do on those as well. And we're going to talk about that today. I know you're excited, okay? Because this is the money part. Okay. So, claims resolution documentation. I'm going to go to the third one first, which is explanation of benefits. You probably know this from your own personal dealings with your health insurance company. An EOB, or a health explanation of benefits, the insurance carrier, the third-party payer, will send this or make available. I mean, my insurance company doesn't send it to me, but it's available on the website. Okay. And this will explain what was asked for on the claim form, as well as what was paid and what the patient's responsibility is. Okay. So that's very important for the patient to keep track of, and this is the benefits of having the policy. Okay. All right. Now let's go back to the top, which is essentially the same thing, the remittance advice or the electronic remittance advice, which in 2023 and going forward, most always these are sent electronically. Okay. And basically, it's like the EOB, where it lists out the claim form, all the details about the patient, the date of the encounter, the codes that were claimed on the claim form, and then the status of that and how much they paid or did not pay. Okay. Now, the thing about the remittance advice that is different from an EOB is obviously an EOB goes from the third-party payer to one person, the beneficiary, right? Okay. Whereas the remittance advice will be from the third-party payer to the provider. And if you have filed several claims or claims for several different patients with your practice or your facility that happen to have coverage in the same third-party payer, which is not unusual at all, the remittance advice will show for each patient. So you may have 5, 6, 7 patients all on one remittance advice, which means you have to go over them carefully. And also, there may be a line item rejection or denial. I mean, you might think that a denied claim is going to be the whole claim is denied, but that's not necessarily true. What it may be is this is accepted and paid, this is accepted and paid, and this is not. This is denied or this is rejected. Now, essentially, the difference between a rejection and a denial. A rejection is going to be more likely a typo or something to do with the demographics of the patient. However, a denial says you coded it, the diagnosis codes, the procedure codes, and we're not paying for that. And that's what we're going to go over today, the different reasons for denials. If it's a rejection, it might be because there's a typo in the policy number, or you misspelled the patient's name, or an outdated code was used, a code that was deleted last year. You can't claim that on the claim form. One of the really important reasons why it's always important that the coders always use the current code set. Okay, so let's move on. All right, so one of the first reasons that a claim might be denied is due to office personnel error. And when I say office personnel, that includes the physician in the documentation, as well as the coder or the person who admitted the patient and put them in the computer the first time. It's, it's not unlikely that whoever's doing your reception work or especially with new patients, that if you have a really good friend or your name is Jamie and it's spelled Jamie, and you get a new patient that you're putting into the computer and that patient's Jamie but Jamiy or YE or some other spelling, sometimes your human brain can make a mistake and type what and you don't even realize it until the claim gets rejected because we don't have a patient with that name spelled that way that goes with this policy number. Okay. So it could be a simple typo like that. It could be something that when entering the codes, I call it finger dyslexia. Okay. So instead of typing 2-3, you accidentally type 3-2. Yes, it happens. We're humans. We don't like it, but we make mistakes. Even the physician might make an error in the documentation. Okay. Whatever it is, you as the biller are responsible for querying, for making sure that all those I's are dotted and in the right place, and all those T's are crossed and in the right place. Okay. So this is not a terrible thing, okay? Because you can correct the claim, and then following that specific third-party payer's instructions, you can mark the claim corrected claim so that there's no mistake that you're double billing, which is fraud, okay? And then it'll be fine. Okay. Now, of course, we're trying to teach you in this program, it's your responsibility to always go back over your own work and check everything. Read it backwards, read it upside down, have somebody else read it for you. Make sure you don't have mistakes before you hit that submit button. And that should be your habit by the time you graduate. I want this to be automatic, that you don't even send an email to your friend without rereading it first. Yes, we're all in a hurry. It doesn't take as long as you think. But the results on the other side are much better. Okay? All right. So, and mind you, the remittance advice will tell you what is wrong. They're not just going to say denied, you go figure it out. You have to read the little tiny print at the bottom of that section, the bottom of the page, sometimes on the next page. Okay. Sometimes they'll use a little error number 2, and then you got to go 3 pages down because it's electronic and see, oh, error number 2 is we don't have a patient with that name with that number, which means we have a typo. Okay. Considering that you checked it beforehand. Okay. All right. So you send a corrected claim, it's marked corrected claim, and you're good to go. Now, this is a little tricky, denied due to lack of coverage. And this also happens. Now, the first thing, and remember, we talked about doing eligibility and verification when the patient makes the appointment, so that there are no surprises on the day that the patient comes. So this should all be settled, and there should be notes in the patient's record that eligibility and verification was checked. So if it's denied due to lack of coverage, then you have to look at why exactly it was denied with the reason that the patient was not covered, and then address this stated reason only with the third-party payer. And we're going to talk about official appeals in a few minutes, okay? All right. Due to lack of medical necessity. Now, and I just need to tell you this as an aside, due to lack of coverage and due to lack of medical necessity can also be false denials, okay? And I'm going to tell you what is true, all right? What is true is I was teaching on ground, and we were talking about this exact thing. And I said, I cannot prove it. I'm sure I never could prove it. But a part of me thinks that third-party payers do, okay, today's number is 7, which means you deny every 7th claim that comes across your desk without even looking at it, okay? And then it's up to you, the biller, to say, hey, wait a minute, this is all correct. And then they'll go, oh, we're so sorry. And then they'll pay it. And actually, there was research done that showed 85% of claims that were denied and resubmitted for one way or another were paid. Okay. But so I'm teaching on ground, and one of my students raises her hand and she says, Dr. Safety and I used to work for a third-party payer, and you're right, they do that. Okay. Now, this is not something I'm accusing any third-party payer of. I'm saying it to you so you understand that just because a claim was denied does not mean that's the end of the conversation. Okay? If you know that you're doing right. So if this is the case, either for coverage or medical necessity, the first thing you need to do is go back and confirm the diagnosis codes. Not only are they correct, but that they were entered on the claim form correctly. The same thing with the procedure codes, because remember, they got to go together, right? So this could be a typo. This could be yeah, we just didn't like the color of ink you put on that electronic form, which there's no ink, It could be anything. But my point is you need to stand up for what's right. And you may need to resubmit. Okay? I find that when you call the 800 number for customer service for third-party payer and you don't scream at them, and you just say, hey, can you help me out? They will work with you. You will not get pushback. Okay. You just say, hey, pull this up, help me figure out, and sometimes you could play the, oh, I'm going to get in so much trouble. I don't want to lose my job. What the point is that everybody's working for the same purpose, which is for the benefit of the patient. And you want to make certain that you are doing that. And if you end up working for somewhere where a claim is denied or rejected, and you are told, well, just send an invoice to the patient without anything else, that is wrong, wrong, very wrong. Because the patient has no idea what a correct diagnosis code is or a correct CPT code. They have no idea of any of this. They didn't come to this class. You are the professional. You need to stand up for your patients as well as your provider and make sure the work that was done is properly paid for by the person or people who are obligated to pay for it. You don't want that done to you or your family. Don't do it to your patients. And so you may need to educate a little bit in your office. Don't assume because the office has been there for 30 years that the personnel in this department prior to you were educated and competent. We should never assume, never in healthcare. Okay, so you're going to go back, you're going to check your diagnosis codes, make sure the code that's on the claim form is reporting what you think it's reporting. Okay, and make sure the procedure codes match. All right. You don't want to be reporting an upper respiratory infection, a URI, with a procedure of a urinalysis, which might result in the patient being diagnosed with a UTI, upper respiratory infection, urinary tract infection. In a busy day, it's easy for us humans to make a mistake. So it's important that you stand up for these rights. Okay. Now, every third-party payer has its own published medical necessity criteria. And some of them are a little different, but for the most part, these 4 items are universal. So the first thing is A, is commonly performed by healthcare practitioners, considered accepted standard of care for the treatment of the condition, illness, or injury as indicated by the diagnosis codes provided. So again, this is what we've talked about a million times. Your diagnosis codes must support your procedure codes and vice versa. Okay? They said it more fancy, but I'm telling you, these two things need to go together as per the documentation from the physician. All right. B, is provided at the most efficient level of care that ensures the patient's safety. All right. This basically is saying no upcoding. You got to do it at the level is necessary. Okay. And that includes your diagnosis codes. No coding acute and chronic if the doctor did not specify that. And no, reporting for an entire hip to ankle cast when the patient broke a toe. Okay. C, is not experimental. And this goes back to the first part of A, is commonly performed, because mostly their definition of experimental is it has been accepted as part of standard of care. This is not a new drug that just came out. This is not a new procedure or treatment it's brand new. Nobody else is using it yet, which means if nobody else is using it yet, it's probably not going to be reimbursed. Okay. So it's great to be on the cutting edge, except that insurance companies are not going to pay for cutting edge. They're going to wait until the majority of physicians in the United States in that specialty accept this as, oh, we're going to be doing this from now on. Okay. This is what happened when we went from open to laparoscopic surgery. It took a while. It takes a while. There are a lot of people, a lot of doctors out there that are afraid of change. Okay. You may be working for a physician who loves the new. Oh, this is brand new. We're going to try this. Okay. Well, that's great. That's great for the doctor and mostly great for the patients. But you in the HIM department are responsible for determining beforehand if the patient's going to have to pay out of pocket because that procedure is considered experimental. And that's part of eligibility and verification. Okay. All right. And it is not elective. And that means we're not just doing this because the patient wants to. There has to be medical necessity. Okay. Which is why cosmetic procedures are not reimbursed by third-party payers, because the only reason to have that facelift is for the individual. There's not a medical reason to have a facelift. There's no diagnosis of, when I look in the mirror, I see an old woman. That's not a diagnosis to support having a facelift. So they're not going to pay for it. It's got to be patient. But those two things, your responsibility for making sure that this is known before the patient has the procedure. Because in these two, C and D, there's no question the patient's going to have to pay the full boat out of pocket. A and B could be an issue with the coder, okay, and interpreting and deciding what to report in that. Okay. So this is really very important. And some of it is before and some of it is after. But especially when you're working in a facility, you get to know what they're doing and you get to determine this up front. And never, never, never assume. Like if you checked and said, well, United considers this experimental, where they're not going to pay for it, but Aetna might pay for it. So you have to check for each. But the good news is this is only going to change once a year. So maybe you keep a notebook on the side where you keep notes and you can keep track of these things. I know, notebook, paper, pen. What are you kidding? How old-fashioned. All right. Denied due to a benefit limitation on treatment by an assistant. So this could be something where they don't want a medical assistant doing it, even if medical assistants are perfectly capable of doing it. I mean, this could be something like a flu shot, okay, to keep it simple. It is your responsibility, again, to know this ahead of time as to what the coverage is, okay? But before and in addition, I wanted to point out to you, wait, I need a little drink. Excuse me. I want to point out to you, first of all, there's a difference of credentials, okay? I worked with a doctor of acupuncture who discussed nutritional recommendations with the patient. The coder mistakenly reported this as a nutritional assessment or a nutritional consultation, and it was denied by the insurance company, because when you read the CPT code description, it actually says that that consultation, that code, can only be used for a certified nutritionist. So they denied it for lack of proper credentials of the person. Okay. So it could be one of those, and one of those circumstances. Um, and that is something for the coders to pay attention to. Okay. Uh, in other words, the nutritional advice should have been included in the evaluation and management code. Okay. The other thing is what we call physician incident to. And and if you've ever gone to your doctor for a flu shot, this is the time of year for that. So if you've ever gone to the doctor to get a flu shot, and you'll notice you talk to the doctor, yes, I want a flu shot. Okay. The doctor writes it in the notes, types it in the notes, and then the doctor leaves and the nurse comes in to administer the flu shot. As long as the physician is on the premises, that is considered incident to and can be reported as the physician administering the flu shot, and not a nurse or a CMA or somebody not a physician. Okay. So again, this is your responsibility to know the qualifications of each person doing what, how it is stated in the documentation, and the third-party payer's written policy with regard to that. And again, each third-party payer. And again, this is going to be right on their website. But you can, if this is something that you have to deal with often, then you might want to print out that page and keep it handy to remind you of how that needs to be billed or how that needs to be stated. Okay. All right. So this is coming down to the fact that you have to know in advance what all these different insurance carriers, these third-party payers want and need, and then you have to match that. This is not a job for uneducated and people who don't pay attention. Okay. All right. So we went through all the different possible reasons why a claim may be denied or rejected improperly. Okay. Your physician, the documentation, the codes, this claim form is a thing of beauty. It is a clean claim as we refer to it, but still yet they said, we're not giving you any money. I don't know. Maybe you were number 7 that day. Okay. So let's talk about this for a second. 3 things to know when you're filing an appeal is, first, gather all the information about this encounter, the physician documentation, nurse's notes, the actual claim form. Okay. Because I have seen this mistake done is the coders, when a different person, the coders enter their codes here, and then the biller has to transfer the codes onto the claim form, or, click yes, that one. But it doesn't matter what the coders decided where the codes are. It matters what code was actually on the claim. Here's what I found. Nope, sorry. Not now. Thank you. Okay. My watch was listening and it brought me to the page of the Office of the Inspector General. That's very cool. Okay. So the first thing you want to do is get organized and get all the information together. Okay. And I wanted you to know that if this is an emergent situation, so if this is something where the patient is about to be discharged from the hospital or a nursing home and they're not ready to go anywhere health-wise, or if this is a situation where the patient needs medication or whatever it might be, we do have emergencies in our line of work. Okay. So there is what's called a fast decision, and you have to know about that and request it. Otherwise, they're going to take their sweet time. Okay. And then the other thing, which also you will find on the website, is they must tell you in writing how to appeal a denied or rejected claim. They must give you, and you must read it and follow it. Okay? Because remember, these are the people with the money, and you are with the people asking for the money. Now, why should they let go of the money if you're not dotting your I's, crossing your T's, and toeing the line? Oh, wow. Look at all of those analogies, right? Okay. This is your job. This is your job. Okay. All right. So a little example is if you go to www.cms.gov, remember, if you go to medicare.gov, that is the patient website. CMS.gov is the provider website, the professionals. And here are links to show you everything you need to know about filing an appeal or a grievance. Okay. An appeal is you denied this claim, and I really think you should not have denied it. You should have paid it. A grievance is, well, they did not, the doctor did something wrong, or somebody else did something wrong. Okay. So that's like to report malpractice. Not malpractice, but whatever. Okay. I had a student who was interning for a physician, and they actually got overpaid on a claim, and the law says you got to send the money back. But the doctor told them, no, just put it and mark it in the patient's account, and we'll apply it to the patient's next visit. Okay. Well, you can't do that because you don't know that there will be a next visit or what that visit will entail. And it's not your money. It belongs to the third party payer. These are all things that you must be on top of. Okay. All right. Last but not least, what to do if you sent a claim and you receive no notices or payment. So no rejections, no denials, no money in the bank. Uh-oh. So you got to go, you're going to go to the website and check the status of the claim, or pick up the phone and call the 800 number for customer service. Okay. It happens. I know we all think I send an email and you received it. Now, the fact that you didn't respond, it means you're not a good person. Okay. But sometimes, as I've told you, sometimes emails end up in the third ring of Saturn and the person never sees the email. It's the same thing with claim forms. There can be glitches. There can be little potholes on the information superhighway. You may not be old enough to remember that, but anyway. Okay, so and I actually did this is I spoke to a third party payer customer service, and they said, and the provider was saying, you owe us money because the insurance company said they never heard of you, and they're not paying. So I called the the third party payer, and they said we never received the claim form. So the woman was very nice. She gave me a fax number. I called the provider. I said, you got to send the claim, and then this time you're going to send it by fax right to this very nice lady at the third party payer. And boom, they paid it 100%. Okay. So the official term is a tracer, an official request for a third party payer to search its system to find a missing health claim form. You want to do that first before you send a resubmitted copy, because again, you don't want to be accused of double billing, because that's fraud, whereas this is the good one. Okay. All right, that's a lot of information, but thanks to technology, this is all being recorded, and you have the ability to look at it as many times as you like. In addition, if you have a question or you're uncertain about something, you can email me at this email, safiansc@cctech.edu. This is the one that comes to my email box and does not go to the third ring of Saturn. How exciting! Okay, we can email back and forth. We can set up an appointment to speak on the phone. We can Zoom or FaceTime or whatever. And then that way the light bulb will go on over your head and you go, oh, I understand now. How exciting. And remember, virtually all of these concepts are usable to you as a patient or the loved one of a patient, as well as a professional. All right. Have a great day, and I'll see you in my email box if you email me, that is.